Merci beaucoup pour l'invitation, mais je continuerai en anglais parce que mon français c'est pas très bien. Today we will talk about acute intestinal dysfunction, and I will discuss basic pathophysiology, causes of dysfunction, starvation, surgery, inflammation, ischemia and reperfusion, some of its manifestations and some clues for management. Well, intestinal functions are primarily governed by the central nervous system, but additionally by the enteral nervous system, which is a sort of independent unit, also called the local mini-brain. In general, parasympathetic nerves stimulate intestinal functions, and sympathetic nerves inhibit intestinal functions. When food comes into mouth and stomach, there are a lot of activations, and it starts with immune globulin A in the mouth for protection, slime in the stomach, acid in the stomach that reduces bacterial overgrowth, and a lot of enzymes for digestions, and also food initiates enzymes for motility and enteral hormones and neuronal reflexes that stimulate blood flow. And if we go lower into the duodenum, there is a secretion of secretin, cholecystokinin, motilin, and GIP, and all orchestrate digestion and motility. And this is a very intense network. And as an example, I will go into cholecystokinin as a typical networking hormone, and it is secreted in the duodenum. It provides relaxation of the proximal stomach and contraction of the distal stomach, contraction of the gallbladder and secretion of the pancreas, and motility of the intestines and the colon. So it's not, if we want to use all these mechanisms and this networking, we should provide enteral nutrition. If we look at motility, there is feeding motility and fasting motility. And peristalsis is the motility during feeding, and we see segmental contractions and propulsion, but also relaxation, and relaxation is especially important for the stomach and the colon, which have a reservoir function. If we get food into the stomach, there is contraction upward and there is relaxation downward. And if we look at relaxation, nitric oxide is one of its mediators. And we can understand now that in case of inflammation and sepsis, there is overproduction of nitric oxide, and this is one of the mechanisms of relaxation, of dysmotility, of loss of contractions of the intestines. So food into the intestinal tracts has trophic effects, initiates local reflex peristalsis, has an important networking function because it is the food that initiates the production of all these enteral hormones. It helps with immunity and it increases blood flow. So this is the message to for all our ICU patients. We should limit fasting periods, because with fasting we neglect all these important intestinal functions. If we look at fasting motility, there are the migrating motor complexes. They are initiated in the duodenum and they end distal in the ileum, and they have 3 phases, and they are initiated by motilin. And they are a sort of housekeeping motility, which is important because if it is absent, we get ileus and bacterial overgrowth. Migrating motor complexes are primarily initiated by motilin, but also by vagal activity, acetylcholine, and a lot of enterohormones, and also prokinetics stimulate migrating motor complexes. But a lot of our interventions and part of our illnesses inhibit the migrating motor complexes. So look at these. We should limit their administration. We have tried to. Well, this is a complicated picture, and it's made to be complicated because intestinal motility is very complicated. There are disease conditions, there are inflammatory mediators, and there are a lot of our interventions that act on intestinal motility. If we look at clinical conditions that are associated with gut dysfunction, there's primarily ischemia, reperfusion and shock, sepsis, inflammation, abdominal surgery, trauma, fasting. And all of these can initiate gut barrier failure, and as a result, translocation and GNI particles in the serum, as we heard in the previous lecture, and inflammatory response. Well, it's a long time ago that we found that increased oxygen consumption after just uncomplicated cardiac surgery was associated with endotoxin in the blood and the release of inflammatory mediators. This was just an association, but we also looked at the permeability of cellubiose, at intestinal tract permeability, and it was related to the area under the curve of endotoxin. And we made a systemic response score. There was no SIRS yet at that time, and there was a relation between intestinal permeability and the systemic response score. And we found that low CVP and less positive fluid balance and the amount of ephedrine used during the operation was related with the intestinal permeability, suggesting a component of ischemia. Well, tight junctions are crucial for gut barrier. And you see just at the base of the microvilli are the tight junctions which fuse adjacent cells. And there are several molecules, claudin, occludin, zonula 1, and F-actin, which are important for the function of the tight junctions. If we look at what happens at just fasting, so nil per mouth, start enteral nutrition on day 2 or 3, this is what happens. This is a mechanistic trial, just randomized trial comparing early enteral nutrition to late enteral nutrition, and it found that late enteral nutrition was associated with a loss of glucose absorption, so a loss of absorptive capacity in the intestine, a longer duration of mechanical ventilation, and duration of stay in the ICU. This is a very elegant translational study in mice and men, and it looks for gut mucosal integrity. And it looks for the role of intestinal alkaline phosphatase, which is really an interesting stuff, which can also be infused intravenously, and there is currently a larger trial that will be started. But in this case, the intestinal alkaline phosphatase is administered enterally, and I show some results, but the end effect is that it protects gut barrier during fasting. And what does intestinal alkaline phosphatase? It dephosphorylates bacterial endotoxin, and thereby it prevents toll-like receptor signaling, local inflammation, and loss of gut barrier. So this is the mechanism. Well, the study shows, and it looks at patients receiving an ileostomy, and it looks at the first output of the ileostomy, and it found that fasting reduces alkaline phosphatase content of the enteral fluids. And in mice, they did some more investigations, and they looked at intestinal permeability with dextrains, smaller and larger, and they showed that just starving, just fasting for 48 hours reduced the gut barrier, and if intestinal alkaline phosphatase was admitted concomitantly, intestinal barrier was protected. And they also showed in the same study that these are the proteins that are important for intestinal junction function, that they go down with fasting, and intestinal alkaline phosphatase increases protein expression. Well, let's go to ischemia. Ischemia leads to ATP depletion and loss of all sorts of functions. And these are among the functions of the gut. So there are a lot of functions in the gut. In this also translational model, and they used the jejunal isolation model in 10 patients undergoing pancreaticoduodenectomy. So the jejunum was clamped and investigated during the clamp period and then resected later. And they found, there are beautiful photos in that study, and they found that well, the mucosa cells loosened, and there were intestinal there were spaces between the mucosa cells and the deeper layers after 45 minutes of ischemia, and there was a loss of mucosa cells into the lumen, and after reperfusion there was only partially recovery after 120 minutes of reperfusion. And they also found that the basal membrane was exposed to the luminal content 30 minutes after reperfusion. And these are pictures of the tight junctions, and they found loosening of the tight junctions, and they also found translocation of bacterial endotoxin into the blood. And they looked at a lot of inflammatory mediators, and these are pictures of interleukin-6, 8, TNF, messenger RNA expression, and they looked also at myeloperoxidase complement activation, and all were activated during ischemia reperfusion. If we go to sepsis, well, sepsis is associated with ironose activation and abundant NO production, oxidative stress, and TNF. And TNF inhibits vagal nuclei activity and output, and all contribute to ileus and gut barrier failure. So I will not go into all the details in sake of time. And then what happens with surgery? Well, we know surgery is associated with either early, but sometimes also with late post-operative ileus. And early ileus is associated with neuronal activation and has to do with handling of the intestines during the surgery. And late is more an inflammatory problem. And there's local activation of muscular macrophages. And there is an interaction between inflammation and neuronal activation. And if we look at GI resections, it's really a wonder that the gut still functions after that. But there is denervation, there is a stopping of discontinuation of the spinal reflex, which is very important. There is sometimes a changed order of viscera. There is resection of the pylorus and the enterochromaffin cells that produce motilin. So we can understand if there is complicated GI surgery that there is a motility problem. So if we look at clinical studies, and that this is a study that associated digestive intolerance to general sickness, and they found that there was a strong correlation, and they looked at increased residual volumes, and they found that maximum SOFA score days with catecholamines and sedation and prone position were associated with this motility. So inflammation, catecholamines, sedation, that's opioids, and prone position, that's probably also sedation. This is a study, and it was designed to investigate whether we could add an intestinal severity score to the SOFA score, and it was a prospective observational studies in patients were intended to be on a ventilator for more than 6 hours, and we looked at a series of intestinal symptoms, including abdominal hypertension. Abdominal hypertension was very rare in this population, so this were the symptoms we looked at. And we found, and it was really, unexpected, that absence of bowel sounds was associated with mortality on all days, day 1, 2, 4, and 7, with mortality. That diarrhea was associated only on 1 day, and GI bleeding on 3 of the 5 days. And it also showed that bowel distension, vomiting, and high gastric residual volumes were not associated with mortality. They can be a problem, of course, but they were not associated with mortality. And we looked at the gastrointestinal failure score, having 3 symptoms, and patients with that score had a higher mortality. If we looked at the multivariate regression, it was the gastrointestinal symptom score, renal score, and neurological SOFA score that were predictors of mortality. But it was independently associated with mortality, but if we put this score up to the SOFA score, it was not an independent predictor. So it probably indicates that GI dysfunction, and that's what we all feel that's the case, is often secondary to other organ dysfunctions. Well, management, in 5 minutes, so it's really... an important question is early enteral nutrition beneficial? And this is an older meta-analysis, and it was very clear. It showed that there was a higher incidence of vomiting, but a lower mortality when enteral nutrition was initiated earlier. And I think this is important. It's not significant, but there was a trend towards less anastomotic dehiscence. And that's always a discussion with the surgeon. Should we give enteral nutrition, yes or no? And it's probably that if you do careful feeding, that you increase blood flow to the intestines and you diminish mucosal atrophy, you give trophic effects to the intestine, and at least you do not have more intestinal dehiscence. This is a very important surgical program, early recovery after surgery, and if we look at the parts of the program, it's focused on enteral preservation. No enteral bowel preparation, preoperative oral carbohydrate administration, early mobilization, early enteral feeding, and stimulation of defecation. So if you implement... I miss a lecture. Well, stimulation of defecation, I think there was a discussion yesterday. Is it important, yes or not? I think it is important. If you leave the colon with all these features, you get bacterial overgrowth. And bacterial overgrowth, you get an inflammatory stimulus to the mucosa, and you have a higher chance of increased of loss of barrier function. And this is very similar. It is also an old study, but you can use neostigmine in a very slow and gradual infusion, and in most patients with just the colonic ileus, without that have enteral feeding, you can easily get defecation. It's safe and simple, and as soon as you have your defecation, you stop the neostigmine. Well, if you implement the ERAS protocol, this is a before-after study, and it is both in open and in laparoscopic resections. You get an earlier discharge of your patient from the hospital. Well, this is always the question. The patient is on vasopressors. When should we initiate any enteral nutrition? And this is a Swiss study, prospective observational, and it was done in patients, in cardiac surgery patients, and they all had circulatory failure, and the majority was on noradrenaline, and they showed there were no complications related to enteral nutrition. They said, well, we could only deliver 70% of the energy in the first 2 weeks. Well, it should be better, of course. We should aim at a better target. But if we look at other nutritional studies, it's what they all find. This is also a point of discussion. Does enteral nutrition increase the risk of bowel necrosis? Well, there are indeed occasional reports, but they are nearly all in patients receiving enteral nutrition via a surgical plesionostomy. And it's not, there are no reports in medical cases, so it's likely associated with the surgical intervention. And I think that we are more reluctant to place these tubes now. Well, there is a change in the landscape in early enteral nutrition, and nowadays there is the meta-analysis do not show lower mortality. They only show no difference in infections when enteral nutrition is started early, and the same holds true for early enteral versus parenteral nutrition. And interestingly, I think the difference that parenteral nutrition is bad is especially for the cases where there was overfeeding with the parenteral nutrition. Well, it's too much to discuss now, but overfeeding is a bad case. And this is a very confusing trial. It's a randomized controlled trial for early versus this early enteral nutrition versus parenteral nutrition in patients that could tolerate both. And they found it's only for 5 days, and so it's not a clinical question. I don't understand this study. But they found, and I think this is very interesting, that energy intake was too low in both arms. So parenteral nutrition is not a guarantee for achieving your nutritional goals. And there was no difference in mortality. Well, let's conclude. Both disease and iatrogenic factors contribute to intestinal dysfunction. And, well, in the management, we should limit fasting periods. That's really important. I think that's the thing we can do in daily practice in all our patients. Provide early enteral nutrition, and if it's difficult, at least continue a low dose of enteral nutrition, minimize opioids, dopamine, promote epidural anesthesia, mobilize early, and, well, probably this is something for the future. Thank you for your attention.